Thank you very much for that kind introduction. Now I have to say that I was a bit confused because I don't know whether I have 15 minutes or 20 minutes here. So I prepared for 20 minutes, given that Dr. Helena Teed after me said that it was 20 minutes. So if you've got no time for questioning, that's her fault. So without further ado, because it's such a press for time, but first of all, we talk about bone and diabetes, and they are both huge topics in their own right. Wait a minute. Yeah, I have no financial disclosures for the purposes of this talk. Now, if we take a look at this IDF atlas here, and if you see that 1 in 10 adults with diabetes, that's huge, huge. So we are talking about 537 million worldwide. So that's your prevalence. And then on top of that now, we are going to see a 46% increase in the next couple of decades. So this is your diabetes prevalence, very common. What about your osteoporosis ones? 158 million. And again, in that view, it's the same trend we are seeing, except this will go up 2 times, so 100% increase in the next couple of decades to 319. Now, what's also not good about this is you can see that, um, whoops, okay, whoops, sorry, backwards, okay. If you can see here, this is your hip fracture. And why is it people focus on hip fracture? Because invariably you get admitted to hospital, you definitely will find it, other than the other fractures, which is a bit difficult to logistically try to calculate them. But also the hip fractures, international data and otherwise, is 1 in 4 deaths in the next year. So, and this is also going to increase by 240 by 310%. And the problem here is that so because they're all so common, it's very, very common, therefore, for a person to have both diabetes as well as osteoporosis. But the problem then comes that they also affect each other and make each other worse. Now, then the talk will now discuss and focus on diabetes, how it affects bones and increases risk of fracture. What's the risk of fractures then in type 1 and type 2 diabetes, and the clinical implications of this using a case study. So I'm not going to belabor and go through the entire thing. Suffice it to say, how does it affect bone? These are the mechanisms. You have microarchitectural abnormalities. You have macroarchitectural abnormalities. Most of them are common for both type 1 and type 2 diabetes. Type 1 has slightly increased more. I will talk about that in the next slide. But under this is obviously one is the advanced glycation end products that will cause impact on both micro and macro architectures. And then for the type 2 diabetes, your TZDs and possibly SGLT2, specifically chylglyphosin, and all this leads to a reduced resistance to mechanical fractures. What is a little bit more specific for diabetes or unique to diabetes are the other causes here in which the other situations here in which hypoglycemia, you have got the complications of diabetes such as peripheral neuropathy, foot ulcers, amputations, and this all increases the risk of falling, and therefore this also increases the risk of fractures. And the problem here is that a lot of people don't see this because for type 2 diabetes, they actually fracture at a higher T-score. What is the additional issue for type 1 diabetes? And this is a good time then to go through to show actually if you really want to prevent diabetes, it starts from very, very early on, as in your childhood, is your teens. Because if you look here, by the age of 20 to 30s, you are done. The peak bone mass is there, and then it continues constant, and then there's an accelerated loss beginning at menopause with a gradual loss later. Now, one of the things about the world is gender bias, but in osteoporosis, it's actually the opposite direction, giant gender bias against the males. So lots and lots of data for female, not as much for males. So one token male, something for the male. So the male doesn't have that sudden drop because, well, we don't really exactly have menopause. And so it goes, that's your males here. So what happens in type 1 diabetes is that the genetic potential is not achieved for the bone. So therefore, in the beginning, because they are diagnosed earlier, you end up with a lower peak bone mass. Now, even if they continue it throughout and constant, but you already started off at a lower playing field, and therefore it's a bit more devastating for them. And not to mention, there's this longer exposure time to the AGEs, the advanced glycation end products. And with this longer exposure time, there's also increased risk of complications, and that therefore increases the risk of fractures. So that's for type 1 diabetics. So let's talk about then what the risks of fractures are then in type 1 and type 2 diabetes, and why is it. So what that would then give me what is osteoporosis. If you should quickly, I think we have a um, myriad of different clinical practitioners here. I understand we've got diabetologists, we've got endocrinologists, we've got internists. So let's just quickly go through what exactly is osteoporosis basics. This is a long-winded definition for WHO. I don't remember it. Suffice it to say that I have this model sitting in my clinic, and I tell my patients, they come from different fields, they talk different languages. I just need to point. This is you in whatever language is translated in, and they understand because it's a model. So basically, what is osteoporosis? It is a disease that causes the bones to become weak, brittle, and therefore prone to fracture. And the hallmark of this is the low trauma fracture. So low trauma fractures or fragility fractures, what it means is that the trauma, example sneezing, coughing, bending over, does not justify that one fracture. So low trauma fractures is the hard endpoints to osteoporosis, what heart attacks and strokes are to diabetes. So let's look at then the data then for type 1 diabetes, looking at, remembering I said longer exposure from the very beginning. They are already handicapped against already. So it's no surprising this data. So this meta-analysis of 27,000 subjects with type 1 diabetes, and you get to see that there's a relative risk of any fractures in subjects with type 1 diabetes was 3.1, whereas women 4 times or men 2 times higher risk of any fractures, and the relative risk of hip fractures and spine fractures were 3.78 and 2.88 respectively. Now, this is systematic analysis of type 1 and type 2 diabetic patients, about 840,000 patients. And if you can see here, this is for type 2 diabetes patients. I think it's a bit underestimated. So you have 1.7 because diabetes patients, type 2 is a bit complex, but it is still an increased risk. And this is type 2 and this is type 1, and type 1 is 6.3 times. So compared type 1, type 2, both have increased risk type 1 more than type 2s, and the reasons why we've alluded for previously. Now let's discuss then the clinical implications of this, which will be the thrust of the talk. Now we'll go clinically. So with this, I want to use this subject to discuss this case. 53-year-old Asian female. She's type 2 diabetes, diagnosed as 41 years of age. Is this common? Very common. My youngest, I don't see pediatrics, but the youngest I saw was 10 years old, and she was heavier than me. You can obviously know what drives diabetes worldwide. So she's type 2 diabetes, diagnosed at 41 years of age, BMI 26.3, using WHO Asia Pacific standards and your standards as well. That's class 1 obesity, waist circumference 100 centimeters. Hyperlipidemia, hypertension, HbA1c 8.1%. She's 53. That is not an acceptable HbA1c range. Her medications are metformin extended release 1,000 milligrams 2 times a day, dapagliflozin 10 milligrams, and glipizide 2 times a day. Does she have complications from this? Yes, it's already been 12 years. So she has moderate diabetic retinopathy, she has mild neuropathy, and now she has menopause at 51 years of age. Now, the question then, what do you want to do? I think this is a loaded question, and since I'm giving a bone and diabetes talk, I think we know what I want to do. But would you screen for osteoporosis? I'm very sure you know when you are supposed to screen for osteoporosis. But what about in a diabetes patient, which is so common, it's dime a dozen? This sits in front of my patients in my clinic, and it gives this. So you can see I like this so much because it's beautiful. It tells me all my high sugars. It's got, neuropathy, retinopathy, kidneys, heart, but it didn't have stroke. So I pasted this in myself. And the problem is that I tell them they've got good friends, but they don't have obesity then. So I had to paste it in myself as well with that centripetal obesity here. And I have to paste in a bone as well. Right, so because that is a secondary risk factor of osteoporosis, diabetes, and I think that's important in all these patients. So let's go through this working group. Serge Ferrari, on behalf of the Bone and Diabetes Working Group of IOF, actually came to this little working plan here, which I thought was quite good. And I'll go through this. Don't be intimidated by it. Diabetes, I think important for this. Diabetes. If you had a hip or vertebral fracture, remember, and it's fragility fracture, remember, this is the hallmark of osteoporosis. Treat. This is osteoporosis unless proven otherwise. So this person has osteoporosis. Treat. Now, if they have any other fractures, okay, so now it's good to then, whether fragility, non-fragility, good to initiate workup to see whether this person has osteoporosis and whether it should be treated. So if you see you do a DEXA, I'll just go to the quick one. You do a DEXA. If you happen to do a vertebral fracture assessment and he has got a morphometric fractures, asymptomatic, okay, that you treat them because that is a fragility fracture. You didn't even know you suffered a vertebral fracture. Now, if the DEXA comes back and the T-score is less than minus 2.0, treat for osteoporosis because in diabetes, they fracture actually at a higher T-score. And that's why we are using minus 2.0, not minus 2.5, which is for anyone else who is not who is not diabetes. It will be minus 2.5 is osteoporosis. It will be the same as for GEOPS, the glucocorticoid-induced osteoporosis, also fracturing at a higher T-score. Now then, if you don't have minus 2.5, or the patient doesn't have, let's go to FRAX. What's FRAX? This is FRAX. You can go in FRAX and it comes out and you can put India and you plonk in, they ask you for it and you plonk in. Now you need to correct for diabetes, but there are many ways. Diabetes is not even in the picture such that they don't even have diabetes here. So many ways of correcting it. The fast method would be for rheumatoid arthritis, you put yes and it will come. So when you put calculate, it will come out with a 10-year risk of fracture. Now, whether you treat or not then depends on the country-specific threshold. The Indian Bone and Mineral Research, I think, came up its guidelines about a few years ago, and their country-specific, they took it as 3% hip fractures and 20% major osteoporotic fracture risk, then you treat. Now, the next one then, if let's say you don't have this, you have got no fractures in the patients, then let's look at then diabetes specific chronic risk factors. They're no different for others. Do they have risk factors for osteoporosis? It's just that you're going to then intervene faster and earlier. So if they have, and what are these diabetes specific risk factors? So here we have, so these are risk factors like anybody else. Low bone mineral density, recurrent falls. Disease-specific risk factors, we're talking about a diabetes duration more than 5 years, diabetes medications such as insulins, TZDs, possibly SGLT2, HbA1c more than 7%, and microvascular complications. For this group of people, you will want to also do to assess whether there's justification for treatment. And again, if you've done the DEXA scan, the bone mineral density scan, is less than 2.0, osteoporosis therapy. If it's FRAX, is then after you've adjusted for diabetes, plonk on the rheumatoid arthritis, say yes. And if it's more than the country-specific intervention, you're going to treat. Now, so then if let's say you don't get the country-specific intervention, what are you going to do then? You go back to repeat the DEXA or the FRAX every 2 or 3 years, and then it goes through the cycle. Now, let's say there's no other chronic risk factors. You say that person, okay, I don't think we need to do a bone mineral density. Then what do? Just like with peripheral neuropathy, like all the other microvascular complications. Every year you think about it. Every year you should also think about screening for bone mineral density, screening for that osteoporosis. So it's a yearly clinical reassessment to see whether they fall into any of these categories so that you could initiate that workup and do that bone mineral density to see whether they justify treatment. So this patient, let's say, it's minus 2.1 spine. So these are three regions of interest for osteoporosis that you need to look at. It's not one, it's not two, it's three. It's spine, it's total hip or neck or femur. Any one of you take the lowest score, and that's the one which tells you the diagnosis. If it's minus 2.1, we already said. If it's less than minus 2.0, you treat for osteoporosis. So there we go. This patient, you will treat for osteoporosis. Then if the person happens to come back with all of the bone mineral density regions of interest were more than 2.0, then you are then going to use the FRAX score, and then it's the same thing. You use that FRAX score, you plonk in all those things, you remember to put in rheumatoid arthritis, and you see your 10 years. And this 10 years major osteoporotic fracture risk is 2.5, hip fracture 0.4. Okay, intervention threshold not reached, and in such a situation, I will repeat the DEXA scan again every 2 to 3 years. So that's the chart that I would do for her. So then let's put it as that she's bone mineral density of this osteoporosis I'm going to treat. My next question is, would diabetes control help? So in this prospective study of elderly patients 65 years of age, an HbA1c of 6.5 to 6.9% is associated with the lowest risk of fracture. Now, in this other study in which about 300 over patients, which mean age was 7.6 years and HbA1c was 8.9%, the problem is that 1 year of survival probabilities after a hip fracture of diabetic against non-diabetic patients, that diabetic patient makes it worse. And the predictors of mortality were elevated HbA1c levels. On the whole, in general, 1 in 4 would die after a hip fracture. Mortality is higher for those with diabetes as against not diabetes. So not a benign condition. But then, as we argue, this argument about, okay, do we treat? How low do we treat? But here's the thing, let's be logical. HbA1c is individualized to the patient's comorbidities and age. Now, tighter the control might also mean increased risk of hypoglycemia and falls, and it really depends on the patient. You're going to decide based on any other factors as well. Just that please make sure that you remember about the bone and be mindful about bone when you're deciding on what HbA1c to go. For her, she's 53. I want it as low as possible, so it doesn't conflict with what it says, what it has here. It says 6.5 to 6.9. Well, she's elderly. She's not elderly, but it behooves me to get her to be lower than 6.5% because she's so young. So now we talked about diabetes control. The next question is, which diabetes medications to use? Just a quick thing here, and because in the interest of time, I wouldn't go through everything, but you can take a photo of that. The ones that this metformin, okay, seems as if decreased risk of fractures. Incretins, GLP-1s, fine, seems to increase the bone mineral density, equal or increase. DPP-4, so the ones that doesn't seem to have detrimental effects, incretins, DPP-4, SGLT2s plus minus might increase. Data seen with canagliflozin, insulin, yes, because insulin means that's higher chance of hypoglycemia, also a longer duration with an increased risk of other complications that could increase risk of falls. So next question then is osteoporosis medications. What osteoporosis medications for her? Well, unfortunately, given that it's not even on the FRAX, the osteoporosis diabetes as a secondary risk factor, then there's a paucity of data specifically for use in patients with diabetes. I would say principles are similar to that of patients where the osteoporosis threshold has been reached as to which one you give. So first line is bisphosphonates. Of course, if this patient had renal impairment, denosumab might be a good choice to give if this person cannot tolerate bisphosphonates, or if this person has very severe osteoporosis, multiple fractures, maybe teriparatide, maybe romosozumab might be something to decide. So then one of the last ones now is lifestyle modification. So if you remember this, that, and this is specific for diabetes, of course, then things like insulin, talking about peripheral neuropathy, well, first of all, you try to prevent all these complications as much as possible, which means a great HbA1c throughout the life. And then the other lifestyle would be no different from the rest. Decreasing risk factors such as smoking, observe your drinking limits. This fantastic for Gujarat because it's a dry state, so I don't have to talk about alcohol at all. Ensure the adequate calcium, vitamin D, and weight-bearing exercises. So in conclusion, we talked about the link between bone and diabetes, where diabetes makes it worse, increases the risk of osteoporosis, increases the risk of fracture, even at a lower T score. We talked about the diabetes risk, the risk of fracture for diabetes is greater for type 1 more than type 2, but certainly type 2 is there as well. And with patients with diabetes, you consider that there's unique considerations regarding bone health, which is fracturing at a higher T-score level. Evaluation and treatment thresholds then should be targeted for diabetic patients. We discussed BMD thresholds less than minus 2.0. FRAX, how to use FRAX to get the specific threshold, which is country specific for treatment, and that you plonk in that rheumatoid arthritis there to account for diabetes. We talked about whether control for diabetes helps or not, the medications that you're thinking of considering in terms of diabetes and osteoporosis, and lifestyle modification. So this is the a tall reach, just to show that it's good to have low impact walking weight bearing exercises for weight, for diabetes, as well as for osteoporosis, and also that little sunlight there to give me adequate vitamin D. So thank you very much. Shukriya.